Good morning, everyone. Thank you for joining today's class, which is a continuation of the previous one regarding proptosis evaluation. I'm going to start this presentation again by quiz. I prepared 2 quizzes actually. The first one is almost like that one in the previous class, but the timer is set for only 30 seconds. You don't need to wait until the end of the timer to write down your answer. Whenever you feel you are confident with your answer, just write it on the chat. All right? I'm going to show you some photos. I'm asking about a common theme, a common clinical sign in all photos. I'm not asking about the diagnosis of each photo because each photo has a different diagnosis. Okay? But here, again, another difference. Your answer should consist of 3 words. So I'm asking about a 3-word answer. The full answer should consist of 3 words. All right? Shall we start? Okay. I got the correct answer. It's inferior dystopia on the right side, or you can say right inferior dystopia or inferior dystopia of the right eye. All are correct. I asked for a 3-word answer to, to stress on the importance of mentioning the side. So you have to say which side, right or left, and also the direction of dystopias. So dystopia alone is not enough. You have to say whether it's inferior or superior, nasally or laterally. And if you have a scale, you can also mention how much dystopia in the case. Here, the problem definitely is on the right side, okay? All these photos, by the way, are from references, from papers. I have chosen these photos because all with cornea reflections. So we can have an idea about the ocular alignment as well. So the cornea reflection or Hirschberg test is central in all the cases. It's almost central. So let's go one by one. Here, definitely you feel that this eye is totally displaced, totally shifted downward. You can appreciate this. This is not hypotropia. This is not a usual hypotropia, because in hypotropia, it's a kind of rotation. The globe is actually rotated down, but here the globe is shifted downward. I know the Hirschberg is a little bit higher, but it's almost central. So this is actually inferior dystopia, in addition to proptosis. Definitely there's also proptosis, even from the front view, because, in order to assess proptosis more clearly, we need Worm's view on Afziger and the measurements. But definitely there is proptosis here, and there is like fullness in the upper and lower lid. And according to the reference, this is a case of proptosis and inferior dystopia in a child due to myeloid sarcoma. Okay. By the way, if I ask you, is it axial or non-axial proptosis? This is definitely non-axial proptosis, because by definition, non-axial proptosis means proptosis with dystopia. And we have here, in such a case, inferior dystopia. And this is probably the only photo, the only case in this quiz that shows proptosis, non-axial proptosis. Let's go to the next one, this one. Again, the Hirschberg is central in the pupil of each eye. But if we draw a line here, if you draw like a line, remember the trick I told you in the previous class. If you draw a line, I started from the cornea reflection, the central cornea reflection of the sound eye. So the left eye here is the reference eye. This is the sound eye. I told you in the previous class, if you draw a line from the cornea reflection exactly horizontal, and then you find the cornea reflection is lower or maybe higher according to the case, this means there is vertical dystopia. And like if you imagine that I have drawn a line across the cornea reflection of both sides, it will be oblique. So this obliquity means there is definitely vertical dystopia. All right. But this is maybe not evident because it's like a kind of mild inferior dystopia. All right. According to the reference, this is a case of blowout fracture. So remember, sometimes in orbital blowout fracture of the floor, you know from the references, from studying or from your practice, there is hypotropia. But sometimes there is like, if it is excessive fracture and there is like the globe may be totally shifted downward. So you may get hypoglobus or inferior dystopia in blowout fracture as well. And let's see the third one. So the corneal reflection could be like a spot, like dot. This is it depends on the kind of photographing the case. So here we have like two corneal reflection, because this is depends on the camera flash about the technique itself. So we have like two corneal reflection across the pupillary border, and again the two corneal reflection here across the pupillary border. So generally, broadly, we can say this is like central corneal reflection in both eyes. So there is no squint here. There is no hypotropia in this eye. Okay, the eye here is like totally shifted downward on the right side. So this is a case of inferior dystopia. And according to the reference, it is due to something called fibrous dysplasia. Okay, let's see the last one. Again, the corneal reflection is central on the left eye and almost central on the right eye, and the right eye is totally displayed down. Can any one of you like guess at the diagnosis of such a case? It looks like what? This case, the last one, this one. I will give you a clue. It's a kind of one of the phacomatosis. You know phacomatosis? Yeah. So which kind of phacomatosis? You said neurofibroma, so it belongs to which phacomatosis? Which one of the phacomatosis associated with neurofibromas? Yeah, neurofibromatosis, and most commonly we are referring to NF1, neurofibromatosis type 1. Correct. Now I imagine that if you faced a case like this, let's see this one because this is the most clear one. And if you said to the examiner, there is hypotropia, I'm afraid to tell you this is like a fatal mistake. Okay? Because simply you show the examiner that you can't differentiate between hypotropia and inferior dystopia. And the case is easy because the corneal reflection is central. If you remember in the previous class, sometimes the case is not easy when the corneal reflection is decentered. But here the corneal reflection is centered in the first place. So it's very easy, because if you say hypotropia, this means that you haven't seen any case of hypotropia, because simply if you have a hypotropia, the corneal reflection should be decentered superiorly. All right. So be careful and think before you answer. And I have another quiz, but this time I will choose one of you to answer it. So I'm going to show you two illustrations. All right. And you have to, describe each illustration or give me like a comment in each one.
Yes, I am here.
So take your time. There is no timer. So can you give me like a comment on the first one, on the left side, and on the right side?
In the left side picture, the eyes look straight with the Hertzberg's test as central, and in the right eye picture, it is.
So both are like in Hirschberg testing, and as you know, Hirschberg testing, the patient is fixating on a light source. So there is no here levoversion or dextroversion. Here the patient is asked to look at the pentosh, and the corneal reflection is central here and central here. So what is
then centered, then the left is lateral dystopia, left eye.
And what's this? What is in red here?
Some tumor pushing, some
exactly.
space accompanyingly pushing left side.
So exactly. So here it's a case of lateral dystopia, but since it is mild, the fusional reserve rotates the eye to keep it aligned with the other eye. But this is illustration is not 100% accurate. This eye looks like abeducted, but it's actually totally like shifted laterally. Excellent. Thank you, Dr.
Okay.
Aslan. So I am showing you an example exactly like from a reference like this one on the right side. You see? But again, there must be some deformity, some like a clue that guides you that this eye is laterally dystopic. So this is a case actually according to the reference from the British Medical Journal. So as you can see in Hirschberg, like photographing by the camera flash is the central. But if we do our measurement, remember how we measure or how to assess horizontal dystopia. If we measure the distance from the corner reflection to the midline, definitely it is larger than the distance from this corner reflection to the midline, because this eye is laterally dystopic due to frontoethmoidal mucosis. And this is post-operative after surgical correction or surgical evacuation. Okay, so this case somehow similar to the previous illustration that I'm showing you, this one. But because it's better to understand from a case. All right, let's start the class. Back again to checklist. Again, in order to repeat, we finished inspection, and after that measurements, palpation, then two vascular phenomena, variability with valsalva and pulsations. So try to say pulsations, because previous class during editing, I noticed that I said pulsation. It should be plural, pulsations. And then auscultation. And today we'll start by motility and strabismus exam, like cover tests. But I'm just shed the light on it very quickly, because this is not about strabismus evaluation, or we will cover this in detail in strabismus classes. So let's watch the video at first. Despite that I wrote motility and cover test in the video, I started by the cover test. Just watch it. I'm starting here by doing cover tests. We have different types of cover tests, but since I'm holding right now an accommodation target, so I'm going to check the ocular alignment at near. So at near, you should use an accommodation target, and this is one of the important tools that you should have when you are going to the exam. And could be anything, like accommodation target could be like a sticker, you stick it on the tongue depressor, anything written fine, like small font. But don't ever, never, forever use pen torch when you are doing cover tests at near. So cover testing at near should be done with using accommodation target. All right. And of course, you need to have you need to have an occluder. So I'm here quickly. I started by something called cover uncover, and then this one is alternate cover test. And this patient or this volunteer doesn't have any issue regarding ocular misalignment. And then I asked him to look at distance, and again to do cover uncover test, and then alternate cover testing at distance. Here, I'm going to test the motility. Basically, I'm showing you that just version testing, because we have different types of motility testing. In this video, I'm just showing you version testing. What the meaning of version testing means both eyes are open. There are different modifications regarding how we test ocular motility, but here I'm testing the horizontal first, because most of the time when we have an abnormality, usually in the horizontal gaze, and then up and out, up under left and up under right. And I try to keep the lower at the end, because in order to test the motility, the down gaze, like down and right and down and left, you have to elevate the upper eyelids or to observe the eyes. So here down and left, and here down and right. Then you usually end our motility testing by the up gaze and down gaze. Okay? So this is the up gaze and down gaze. Here is my question. Why in this case I didn't elevate the upper eyelids on down gaze? Once more, I just told you that when we are testing motility down, like in down position, we have to elevate the upper eyelids in order to watch the movement of the globes. Yeah, exactly. Because remember, we are demonstrating something related to proptosis. So in order to not miss a sign like lid lag in down gaze. So I was checking also one of the signs of thyroid eye disease, lid lag in down position. And in my area, some of my colleagues and professors are very interested to know the names of each and every thyroid eye signs by the name of the scientist. Does any one of you like name what we call this sign, lid lag in down gaze? So lid lag in down gaze is one of the thyroid eye signs. So it's a von Greve sign. And I remember when I was like medical students, I use like lid lag, there is G, so it should be von Greve, and because there is G also in von Greve. Okay, excellent. And so what I'm showing you right now is testing convergence. Again, convergent testing is relevant in strabismus evaluation and again in thyroid eye disease because one of the signs of thyroid eye disease is lack of convergence. Okay, before I move to the next slide, I want you to write on the chat, just give me some examples of orbital disorders with limitation of ocular motility or strabismus. Again, mention some examples of orbital disorder that can lead to strabismus or limitation of ocular motility. Okay, let's go one by one. So thyroid eye disease, to try to be creative because you already mentioned thyroid eye disease, so try to be creative, try to like brainstorm or like think of another cause. Yeah, thyroid eye disease is correct, but we have other examples. Blowout fracture. Okay, all right, but here I need a specific answer. So for example, you can say thyroid eye disease, then dash or like hyphen, what kind of strabismus motility? Because you know, if you say thyroid eye disease can result in limitation or strabismus, you have to be more specific. Which kind of strabismus? Can we get, for example, exotropia? Is it common? Is it common to get exotropia with thyroid eye disease or not? Again, I will repeat my question. Is it common to get exotropia with thyroid eye disease or not? Yeah, no, it's not common. Why? Remember, whenever I say why, so I'm testing your depth of knowledge. And this actually happens and will happen in your exam. Which is the most common form of strabismus in thyroid eye disease? Remember, I've shown you a photo of thyroid eye disease, I think, in the first part of a proptosis evaluation. Yeah, exactly. So hypotropia, this is number one. Esotropia is number two, because you know there is somehow an order of frequency which muscles are commonly affected in restrictive process in thyroid eye disease. So the first one, so exactly, Dr. The most common muscle is the inferior rectus muscles, followed by the medial rectus muscle, and then the superior rectus muscle, and the least one is the lateral rectus, and there is some debate regarding obliques. So the most common is inferior rectus muscle, so you may expect limitation in up gaze, and you may expect hypotropia. By the way, if you notice exotropia in thyroid, you may suspect of myasthenia gravis, because you know myasthenia gravis can affect any muscle, so it might affect the medial rectus muscle. Okay, myasthenia gravis can cause medial rectus muscle weakness and result in exotropia. So now remember, if you notice exotropia or ptosis in a case of thyroid eye disease, you may suspect of associated myasthenia gravis. Okay, and the one who mentioned, Dr. She said blowout fracture. So we have limitation in up gaze, and sometimes in blowout fracture, so you have to be more specific. So you have to say, for example, blowout fracture of the orbital floor, because we have blowout fracture of the medial wall. All right, so medial wall and inferior wall are the weakest wall. So if you are talking about the floor, you can say limitation in up gaze because of incarceration of the inferior rectus muscle in the fracture. So you may have like hypotropia with limitation in up gaze. And by the way, if there is associated insult to the inferior rectus muscle itself, there might also limitation in down gaze. So in blowout fracture of the orbital floor, we may have limitation both in up gaze and in down gaze as well. So the patient may have like vertical diplopia in up gaze and down gaze. But basically, the most common form of strabismus in blowout fracture with of the floor is hypotropia. So you have to be elaborative and more descriptive in your answer. How about orbital apex syndrome? You know orbital apex syndrome? This is an orbital lesion causing orbital apex syndrome. What is the kind of strabismus here? It's complicated. Okay. We can ignore this question right now. We will hit this topic again in strabismus classes. Just like a hint about when we are testing the motility, we look for the range, the motility itself. Is it normal, or there might be some limitation, okay? Or we can say underaction, or it might be overaction. So this is like the variety. So it could be normal. So the movement of the eye in some direction may be normal, maybe limited, maybe some kind of overaction. And while testing the motility, you may inquire or ask the patient, this is in real practice, is the movement is associated with pain or not? Because sometimes the etiology may be myositis. So during myositis or in active thyroid eye disease, for example, because in active thyroid eye disease, the muscles are inflamed. So you will find like a generalized limitation of movement just because of the pain and inflammation in active thyroid stage. And sometimes we may ask the patient, is there any diplopia? Sometimes there is no diplopia in the primary position, but in certain cases, there might be diplopia. So while you are checking the ocular motility, you may ask the patient about two things, pain, and you can also notice like facial expression of the patient, and you ask about any double vision in certain cases. All right. Additional points, like while you are testing the motility, you may observe as well not the movement of the eye alone, but also any change in the eyelids. In Duane, in adduction, there is retraction of the globe and narrowing of palpebral fissure. So this is a change in the eyelid position. This is an example. While you are testing up gaze and down gaze, you may notice lid lag, which is one of the signs of thyroid eye disease. So you may observe also the eyelids. Global traction, again in Duane. And pupil, some of the signs of apparent, something called apparent third nerve regeneration is pupil constriction on adduction. But this is like advanced and beyond the scope of the exam itself. But this is like an overall about the benefits of testing the motility. Or what are the information that we can gather from testing the motility. It's not all about the movement of the globes. We can observe the eyelids, global retraction, and pupil. All right. If you have noticed, I didn't discuss how we tested motility and do cover this in details because this is not the aim of this presentation. The next point in the checklist is optic nerve functions, how we tested the optic nerve functions. I will choose one of you to tell me how we can assess the optic nerve function in general in your practice. If someone asks you to assess the optic nerve function in a patient, what are the points that you need to assess?
Good morning.
Good morning.
Yeah, for optic nerve functions, mainly 5 things we have to check. First is the visual acuity of the patient with the Snellen's chart, and then pupil function,
Yes.
the reflexes, direct, indirect. Then we have to check the color vision of the patient, contrast sensitivity, and finally the fundus.
Okay. Anything else?
Sensitivity, contrast sensitivity, I think I've said all 5. Visual acuity, color vision, contrast sensitivity, pupils, and fundus.
Okay, so you covered most of the points. Let's see the next slide. Although you added contrast, I didn't mention the contrast in my slide, but you are right. We can add contrast sensitivity. Thank you, Doctor. Well done.
Thank you.
So instead of saying visual acuity, you have to practice to always say best corrective visual acuity, because this visual acuity, you know, it could be unaided or aided. So you have to say best corrective visual acuity. Color vision, but these 2 points are not relevant in exams. We don't have time to assess these points in the exam. So it's all about pupils, because you can assess the pupils very easily and very fast in the exam. So that's why when we are talking about right now about proptosis evaluation, we are talking about pupils. So in the video, I'm showing just the pupil assessment, how we can assess the pupils. And you said direct and indirect. Try to memorize the 3, direct, indirect, and swinging flashlight test. Personally, I feel that the swinging flashlight test is the most important, and maybe if someone asks you to choose one, we will choose the swinging light reflex. So never ever forget this, because this is very important. So you missed the visual field confrontation. Remember, according to the experiences, I shall say the old experiences, sometimes they ask you to do the confrontation test but I think it's time consuming, and but still you have to know how to do it. So visual field testing is important test. You have to practice very well, and we will cover it in the neuro classes. And it's one of the optic nerve functions evaluation. And fundoscopy or fundus examination, as you said. Some other, you added contrast, yeah, correct, and brightness sensitivity, also correct. But this is the points I covered or I listed in my slide. All right, the detailed description or how we assess pupils and visual field will be covered in neuro classes. What are the causes of diminution of vision? Can you mention some of the causes of diminution of vision in a case with orbital disorder?
Okay, case of orbital disorder, maybe optic nerve compression, or due to corneal exposure keratitis, maybe due to choroidal force.
You mentioned the most important one. Thank you.
Thank you.
So here the order is important. So you have to say, remember I said before, we have two sight-threatening complications in a case with proptosis, optic nerve affection like compression or infiltration, and exposure keratopathy. So the order is important when you are listing the causes of diminution of vision in a case with proptosis. Okay. There are additional points like refractive changes, choroidal folds, or maybe secondary glaucoma and high IOP. Okay, and you can add whatever you like, but try to, mention the first two at first. Patients with proptosis may complain of blurred vision or diminution, or some cases may complain of diplopia, and we will answer this question in the next class, especially if we are talking about non-axial proptosis, like proptosis with dystopia. Some patients may complain of diplopia, binocular diplopia, of course, because of secondary squint. All right, let's move on to the video here. Pupils, so remember pupils. So here, can you write on the chat what I'm doing right now? Right now, I ask patient to look at distance in a bright illuminated room, and I'm holding a torch, like maybe 50 centimeters, and I'm observing the pupils. Yeah, exactly. Excellent, excellent. We start by check for anisocoria. So in order to check for anisocoria, remember at the beginning the room is illuminated, brightly illuminated. So I'm testing the anisocoria at light. And then I ask another person to turn off the lights. And again, if you notice, I am looking above my glasses because of presbyopia, because you have to carefully check the pupil size. So if you are presbyopic, you may need to do your presbyopic correction, or if you are myopic, you have to look above the glasses or remove the glasses. So here I'm trying to check the anisocoria and in dark. And he doesn't have any of them. So after that, since the light lights are turned off, you will see right now doing the swinging flashlight test. So I was lucky because this volunteer had like light colored iris, so it's very easy to check the pupil in such cases. It might be challenging in dark pigmented iris patients with dark pigmented iris. Pupil assessment will be covered in neuro classes. Just a small comment about the pupil. You may be interested to have like pupil gauge, like some sort of printed out. It's available everywhere, by the way. Sometimes it is like on the pen torch, but I think it's not practical because you are already using the pen torch. How you can judge the pupil size by using the images on the pen torch. But sometimes some occluders in the market, some occluder has like a printout about the pupil size. Because sometimes if you have an anisocoria, sometimes we need to say how much is the size of the pupil. Like here it's like 3 millimeters and here it's like 4 millimeters. Maybe helpful. I don't know if it's relevant to the exam or not, but it's just a thought. So this is to answer your question. So if you are interested to measure the pupil size, try to compare the patient's pupil size by which size can match the patient's pupil size. It could be 4 or 5 millimeters and so on. Pupils don't lie. So what's the meaning of this? Pupils is an objective, like patients has never control over the pupil response. So if you notice like relative affine pupillary defects, definitely there is an issue here. There is a problem. You have to search for it. Okay, pupils are objective. It's not like visual acuity and color vision. It doesn't depend on the patient's response. Okay, so that's why it's very critically to assess pupil. In real practice, it should be assessed in every single case, regardless of the complaint. So even the patient is complaining of like dryness or allergic reaction, allergic conjunctivitis, for example, you have to assess. It's considered as one of the ophthalmological vital signs. Okay, you know, in medicine we have vital signs like pulse, blood pressure, respiration, and temperature. Yeah, for vital signs. In ophthalmology we have vital signs like visual acuity, like pupil. So there should be assessed in every single case. This is for fun. I'm going to ask you this question: why I've chosen this photo of a child? Why I used a child's photo in on this slide? It's non-ophthalmic, but it's still relevant because sometimes you may be asked in the exam about things that you don't have any idea about it, but don't lose hope. Maybe with little thinking, like give yourself a few seconds to think and you might know the answer. Okay, but kids can malinger or can lie. So everyone can lie, by the way, it's not only kids. Okay, I will tell you. So the other name for kids or for students, school students, is pupils. So pupils, the other meaning for pupils is children. Okay. So we hope that our children don't lie. Let's go to the next one, corneal protection mechanisms. By this, I mean testing for Bell's phenomena, lag of thalamus, sensation, corneal sensation, I mean, and corneal staining by Roux-Bengal or fluorescein staining. But of course, number 3 and number 4 are not relevant in oculoplastic station because usually we don't have slit lamp, so we can do staining. But you may say this to the examiner, by the way. And sensation is not allowed because usually they don't allow you to do anything that can result in touch or irritation to the patient. So when we are talking about corneal protection mechanisms, we are talking about testing Bell's phenomena and lag of thalamus. In real practice, one of the dreadful complications is to having such a case like proptosis with lag of thalamus and then exposure keratopathy, infection, corneal melting, you know, the end result. So the patient may lose their eyes, their vision, just because they don't have the proper care for the cornea. So we are testing for Bell's phenomena and lag of thalamus not only to assess facial nerve function, because in neuro classes we will go, supposedly we will go through how to assess cranial nerves. So when you are assessing the facial nerve, the cranial nerve number 7, we have to test the Bell's phenomena and lag of thalamus. But here, since we are talking about proptosis and we are afraid of exposure keratopathy, so we are trying to assess the other things that can protect the cornea. Because imagine now that the patient has a poor Bell's phenomena and they have like lag of thalamus and proptosis, they are at a very high risk to develop corneal affection. Okay. On the other hand, if you have like a mild proptosis with excellent Bell's phenomena and there is no lag of thalamus, now the cornea somehow is protected. Okay. Sometimes we add tear film assessment, but again, this is not relevant to the exam because, you know, cornea is very precious. Once we lost it, yeah, we have keratoplasty, but again, we have to protect the cornea because it's very sensitive structure in our body, perhaps the most sensitive structure in our body. All right. I'm going to spend some time talking about Bell's phenomena because, you know, the poll I posted, so let's read it together. When testing for the Bell's phenomena, do you ask patient to forcibly, so forcibly or tightly, the same meaning, so forcibly or tightly close their eyelids, or you ask them to gently close their eyelids? And the majority said forcible closure. And then the next vote is for gentle closure. And interestingly, nobody answered or nobody chosen it depends. Although in clinical practice, you know, sometimes the patient asks you about management, and sometimes your reply is like, it depends. You may have like different lines of management, so you discuss with the patient the benefits or the pros and cons of each line of management. So sometimes it depends. It's not bad, okay? Sometimes it depends is the most accurate and the most political answer, especially when you ask about something controversial. Okay, so definitely those who voted for forcible, they found it in references. They have seen their mentors or their seniors doing this, and they are imitating them. And the others who voted for gentle closure definitely have their evidence also. So then I asked you to do this. Kindly vote after doing the testing of Bell's phenomena on your family members. I wonder if any of you did this, but anyway, because sometimes when you are doing a clinical technique on a patient, like a patient with, let's say, with Bell's palsy, somehow it's different from testing it on a normal individual. And I will tell you why. So actually, the correct answer is it depends. And I will try to convince you why and how. Last thing, I asked to support your answer by reference, and thanks Dr. As, he was the only one who replied to this request. Okay, let's talk about those who voted for forcible closure. It all starts by the history. So let's have a look about the history. In 1823, Charles Bell, a British anatomist, reported this phenomenon. The other name for Bell's phenomenon, by the way, is oculogyric phenomenon, which accompanies forcible closure of the eyelids. He first noted this reflex, sometimes we call it reflex, by the way, as an upward deviation of the eye during attempt eyelid closure in the presence of lower motor neuron facial nerve palsy, Bell's palsy. So when this phenomenon was discovered by Bell, it was in a patient with Bell's palsy, okay, with weak orbicularis oculi muscle. The patient already had weak orbicularis. So while he was testing the orbicularis muscle, remember when you are testing the orbicularis, remember, we ask the patient to forcibly close their eyelids. And then he noticed, because the patient has weak closure, he appreciated the presence of upward deviation. All right? That's why many references, you will notice that in order to test Bell's phenomena, we ask the patient to forcibly close their eyes. Okay? So by the way, from this short paragraph, you learn something, because sometimes we trick some candidates by asking them this question. In Bell's palsy, Bell's palsy, please don't confuse between Bell's phenomenon and Bell's palsy, okay? Bell's palsy is the most common idiopathic isolated facial nerve palsy, lower motor neuron lesion facial nerve palsy. So you have to know this statement as it is. Bell's palsy is a very important topic because it's the most common cause of isolated idiopathic lower motor neuron facial nerve palsy, okay? Sometimes we ask students this question. In Bell's palsy, what do you expect regarding Bell's phenomena? And now I'm asking you this question. In Bell's palsy, most cases with Bell's palsy show good Bell's phenomena or poor Bell's phenomenon? Again, my question. In most cases with Bell's palsy, Bell's phenomenon is good or poor? Yeah, exactly, it's good. And you can notice now, or you can appreciate from this paragraph, it's good. The majority of cases show good phenomena. What is interesting about this reflex, even if the afferent, because the afferent is, the afferent is what? Facial nerve. And the efferent is what, by the way? Regarding Bell's phenomena, the afferent is facial nerve, because you ask the patient to close their eyelids, and the closure is by the orbicularis, and the orbicularis muscle is supplied by the facial nerve. So the afferent is the seventh cranial nerve, and there must be a center somewhere, I don't know, and there is an efferent. So what is the efferent here in Bell's phenomena? What's the efferent? Yeah, exactly. So you have to say the oculomotor nerve, the cranial nerve number 3. The afferent is the 7th, and the efferent is the 3rd. So what's interesting about Bell's phenomena is that even in the presence of facial nerve palsy, like lower motor neuron lesion facial nerve palsy, even just the attempt, so remember here the word attempt, even the attempt of closure, you will have good Bell's phenomenon. And this is very interesting because, in any reflex, if we have an issue in the afferent, usually there is no result. So in afferent pupillary defect, for example, if we have a patient with afferent pupillary defect and you shine the light, there will no response because the afferent is already affected. But here in Bell's palsy, despite the insult of the facial nerve and the attempt closure, you will get a result. You will get upward movement of the eyes. And this is a photo from a reference. So you see patients here. This patient is asked actually to forcibly close their eyes. And this actually a test for the orbicularis. And he couldn't able to close his eyelids on the right side. But even in the absence of the closure, you can appreciate the presence of a good Bell's phenomenon. So it's okay. To ask the patient to forcibly close their eyes in order to test the Bell's phenomena if the patient already, has poor orbicularis oculi. Okay, this is one situation. This paragraph was taken from a reference. I will read it, but I will criticize this paragraph. Okay, I'm going to criticize it. But because this is a kind of debate. Someone said forcible closure and someone said gentle closure. And, some of you may think it's not a big deal, but when it comes to clinical technique, you have to know at least to do it in the right way. So let's read this paragraph and let's criticize it together. The Bell's phenomena is assessed by the examiner gently elevating the patient's upper eyelids using his finger and thumb of one hand. Okay? So notice here gently, because we try to be gentle with the patient. Whenever we do some clinical technique or any test, we try to be gentle, okay? So the first step should be elevating or retracting the upper eyelid, sometimes both eyelids, gently. Then ask the patient to close his eyes forcibly or tightly. This was taken from a reference, by the way. And then observing the characteristic of eye movement. So try to imagine now you are gently retracting the eyelid. And the patient was asked to forcibly close their eyelids. And the patient has like a powerful orbicularis. The end result that you will be struggling to open the eyelids, and you might not able to observe the eye movement because the orbicularis is too powerful, by the way. In normal individuals, they are too powerful. So if you are gently retracting the eyelids, you may not able to overcome the powerful contraction of the orbicularis done by the patient. So this is like confusing for me, and I will show you in the next slide how will be the difficulty if you gently elevating the patient's eye and the patient forcibly close their eyelids in the presence of normal function of the orbicularis. Okay, some of you may have watched this video. It was about mock clinical practice where one of my colleagues played the role of the examiner, and I played the role of the candidate. Okay. But this clip actually before editing. And we don't have a patient, we have a normal individual, a volunteer, okay? So I compiled in this clip, this unedited clip, some of the mistakes I did during shooting this video, okay? So watch carefully. So the first mistake here, in order to test the Bell's phenomena, you have to keep the order. So the first step should be, you start by retracting the eyelids. So the examiner should retract the eyelids, and then you ask the patient to close their eyelids. But here is the first mistake, that the patient here or the volunteer is forcibly close their eyes before my attempt to open them. So the first flaw is this is the first flaw or the first mistake. So flaw is a little bit softer word than mistake. Patient tightly closes their eyelids before the examiner attempt to open them. Okay, this is the first mistake. So then here, this is correct. I started by retracting the upper eyelid and lower eyelids. In some references, they mention that you can retract only the upper eyelid, but I prefer to use both eyelids, and I will tell you why later on. Notice I will do the second mistake. So the second mistake that I was making, that I asked the volunteer to forcibly close their eyelids. So when the patient forcibly closed their eyelids, I couldn't open them. My strength wasn't able to help me to open their eyelids, because the patient is, their orbicularis are more powerful than my ability. Then the third mistake in this video, this is before editing, I said before. So I retracted the upper eyelids, and again I asked the patient to forcibly close their eyelids, because I was following these references about forcible closure. So what I got something called inverse bells. I don't know if you have noticed this or not, but if you notice, there was like downward shifting of the globes, not upward shifting. Even from the facial expression, the patient is like powerfully close their eyelids. So I loved, and my colleagues loved. I tried again with the same instruction. So with the same instruction, I retracted the eyelids. I asked him to forcibly close their eyelids, and again I got the same response. And then the volunteer was inquiring what was wrong in my eye. Okay. Then I remembered that I read in some references to gently close their eyelids. And finally, I instructed him to gently close their eyelids. So again, I retracted his eyelids, and then I asked him to gently close their eyelids. And finally, I got excellent Bell's phenomena in both eyes. All right, I hope you got it. So if you are expecting that the patient has a good orbicularis, you have to ask him or her to gently close their eyelids. So this is the bottom line here. In order to support, because I already had the observation or the experience of testing Bell's phenomena on a normal individual, I searched for a reference to support my view, and I found a reference actually in 2021 about how we tested Bell's phenomena, and we can read it together right now. BP means Bell's phenomenon was assessed here because it was taken from a reference from a research paper. So it was assessed by gently lifting each upper lid manually while the patients attempt gentle closure. So see, gentle closure while observing closely whether upward rotation takes place. If there was no upward rotation, then it was regarded absent Bell's phenomenon. Okay, and this is taken from the British Medical Council of Ophthalmology journal. Sometimes I use both retracting the upper and lower eyelids because, as I said, in some cases we may get like inverse bells. Eyes will shift it downwards. So you need also to retract the lower eyelid to observe for downward movement of the globes. And again, when you are holding or retracting the upper and lower eyelids, you have a better control and better power to, open the eyelids. So it's a matter of preference. But in some references, you may need to retract only the upper eyelid. Actually, I posted before this video about testing Bell's phenomena on myself. So I was like observing my front camera of my mobile, and simply I did it without any forcible closure. And I was retracting only the upper eyelid. So you see, I have a good Bell's. So in summary, I would advise you when you are testing Bell's phenomena to first you have to retract the eyelids, then ask patient to gently close their eyes. And if you didn't get good Bell's, you can then ask for forcible closure, and usually the case has like Bell's palsy. The next point regarding corneal protection is lag of thalamus. All right. So I want one of you define lag of thalamus. What's the meaning of lag of thalamus? What is the definition of lag of thalamus? Yeah, exactly. Incomplete closure of the eyelids So how we can test for lag of thalamus? So just ask the patient to close their eyelids. So you can say close their eyelids. Okay, simply if you say eyes, it is quite understandable. So you ask the patient to close their eyes. But again, when it comes to ask the patient to close their eyes, you have to be specific. Do you ask them to close their eyes tightly or gently? So the same question. Yeah, exactly, gently. Because, you know, we are keen about testing lag of thalamus. Why? Because we need to have an idea about exposure of the cornea during sleep. So during sleep, there is no tight closure of the eyelids. So we need to ask the patient to close their eyelids gently. Okay? This is how we test lag of thalamus. But there is another tip in this I will show you right now, like some missing word here or missing instruction. So don't say ask the patient to close their eyes and that's it. You have to say ask the patient to close their eyes gently. Okay? Here, let's read this paragraph. This is the accurate method for testing for lag of thalamus. So lag of thalamus was assessed again because this was taken from a reference, and this is why it was, but I should have adjusted to is. So lag of thalamus was assessed in this paper by asking the patient to extend his neck. Okay, and gently close their eyes or his eyes, because in this reference he was talking about a patient. Gently close his eyes. So gently is a key word and important, because if you did the test wrongly, you will get a wrong result. Okay. Gently close his eyes in an active but not forcible fashion. So here the reference is stressing about the importance of gentle closure without any forcible fashion. And then, because this is a research paper, so they are trying to document every finding. So then measuring the amount of lag of thalamus by a ruler to see how much is exposed, how much of the globe is exposed between the upper and lower eyelids. But my question here, what's the importance of this underlined bold words? Ask the patient to extend his neck. What's the importance of this? Yeah, exactly. Because, you know, if you imagine, unfortunately, I don't have a video or a photo about this. Sometimes if the patient like straight ahead, like the head is aligned and there is like minor or subtle gap, like subtle or minimal lag of thalamus, it might not be visible to you because of the eyelashes, I don't know. But if the patient is extended his neck, and if you are, you know, looking from below, you can appreciate like a minimal lag of thalamus. This is the same idea as when you have a case of mild proptosis. You may miss it in the front view, but if you do worms view, you can appreciate, you know, the proptosis. Try to do it on whatever patient or whatever volunteer you have, and you will notice and appreciate the benefit of extending the patient's neck. This is how we test for lag of thalamus. So then in Bell's testing, we said we ask the patient to gently close their eyelids. And for lag of thalamus, the same, we ask the patient to gently close their eyelids. So when we do ask the patient to forcibly close their eyelids, there is a test that we need to ask the patient to forcibly close their eyes. What is this test? Yeah, this test is done when we are testing the tone of the orbicularis muscles, like in the case of facial nerve palsy, like in this video. So again, in this video, because it was all about facial nerve assessment, so ask patient to forcibly close their eyes, and you know, the resistance, you will notice resistance to opening their eyelids. This means a good, powerful orbicularis, and you can observe the eyelashes are buried. So this means good orbicularis function. So try to appreciate the subtle differences between how to assess for Bell's phenomena, how to assess for lag of thalamus, and how to assess the tone of the orbicularis in a case of facial nerve palsy. By the way, assessing for lag of thalamus and Bell's can be done not only for facial nerve evaluation, but for other things, like here in proptosis. So in a case of proptosis, we have to assess for BIS and for lack of soundness. Again, in ptosis evaluation, we have to assess both. I posted this question: any case with proptosis can develop red eye, true or false? And I got the right answer. Any case with proptosis can develop red eye because of exposure keratopathy. For example, this is from the American Academy. This child has optic nerve glioma and then developed exposure keratopathy. And so if you, while you are studying, so optic nerve glioma can lead to proptosis and dystopia in a quiet eye. So you might expect a white eye, like without redness, but since this child developed exposure keratopathy, it looks like a malignant, but it's not a malignant rhabdomyosarcoma or something. It's not a malignant because, you know, optic glioma in children is not malignant. But the redness here is all about exposure keratopathy. So the next point is thyroid eye signs and thyroid examination. This is from Kanisky, just a photo about goiters who have to inspect and examine for goiters and some systemic manifestation of thyroid eye disease like acropachy. But again, if you want to like examine the thyroid more like specifically and more accurate, you can check YouTube videos, because you will find a lot of videos about how to examine the thyroid. About the thyroid eye disease, we will mention some of them in the next class, because the next class will be about common scenarios, common cases in the exam, and definitely the most common case is thyroid eye disease. Regarding the sensation, we watched the video about sensation before in the previous class, so I will skip this slide. But my question to you, remember the infraorbital nerve is important when it comes to orbital floor fracture, blowout fracture, and remember the infraorbital nerve is a branch of, so fill in the gaps. The infraorbital nerve is branch from, maxillary nerve. So remember, this is not, it's not from the ophthalmic nerve, it's from the maxillary nerve. And you have to be aware about the areas supplied by the infraorbital nerves, which are areas supplied by the infraorbital nerve, which are, answer it, cheek, lower eyelid, and the upper lid. Exactly. And side of nose. The next point is regarding ocular examination, anterior segment and posterior segment and intraocular pressure. So here, let's watch this video. This is not applicable in the oculoplastic station because they don't provide you with a slit lamp, but this is in general. Because during discussion, you may tell the examiner that you need to check the face on slit lamp to do like full evaluation of the eye. And don't forget, if we are talking right now about the anterior segment station, you have to examine both eyes, unless it's specified by the examiner to examine one side. You have to examine the side mentioned by the examiner. I'm going to ask you some questions during this video, so watch carefully. So right now, what I was doing, exactly. So I was checking for cells and the flares in the anterior chamber, because actually this patient or this volunteer underwent ICL, implantable contact lenses. And actually I was really examining him. And so here, my second question, not a question actually. So observe my right hand, I was like turning off the light. And this is relevant in your practice, in your examination. So once you finished a tool or instrument, you have to return everything into place, turn off the lights of the slit lamp, keep everything clean and tidy and organized as it was. And then here I was acting. I wasn't actually measuring the intraocular pressure, but here it's very important to comment on the IOP on the intraocular pressure in a case with proptosis. And this video just only for, again, to engrave in your mind the importance of fundus examination in a case with proptosis. So my question to you right now, what are the possible signs that you could see in a case with proptosis? You can type on the chat. Basically, there are like 4 signs, according to Kanisky, that could be seen in a case with proptosis. Yeah, choroidal folds, optic disc edema, right? Hyperemia, all right. Okay, diatoceous veins, okay. Optic atrophy, exactly. So these photos actually from the sixth edition of Kanisky, they are not clear. But there is one is important, yeah, mentioned. Thank you, Doctor. It's opticociliary shunts or collaterals. So try to remember this sign because you may get in the exam, who knows? And yeah, don't miss it. So these are some of the signs that you may see in a case with proptosis. So in the recording version, we present the full video at the end. So the checklist is done finally. And this slide is about tools we used in proptosis evaluation. So let's read them together. So first one, that you have faith and confidence, of course, and a white coat is not mandatory. Masks also at the moment are not mandatory. Pen torch you have to bring 2 just in case one doesn't work during the exam. Occluder, remember occluder, we need occluder for strabismus evaluation. And also, if you remember in dystopia, if we have like a decentered reflex, this means there is you have to use occluder in order to get a central reflex of the dystopic eye. Accommodation target, or it could be near card, just in case you are to test the cover test at near. 2 transparent rulers. 1 is not enough. You have to have 2. And it should not be metallic. 90 and 78 diopter or plus 20. Actually, these are required in the posterior segment station, not in oculoplastic station. But we mentioned them in this evaluation, like in clinical practice. Load exophthalmometers or like Hertel's exophthalmometers, not needed. But since I mentioned them in our series, I used this mark. Visual field is needed in proptosis, but again, if you are asked to do visual field, usually in neuro station, not in this station. And you have to have both red and white. Soft tissue, if you remember, for doing Valsalva, we need soft tissue, and also for sensation testing. The last 2, actually, stethoscope is just like a fancy, but I think nobody needed to have a stethoscope in the exam. But since I mentioned that in auscultation, I wrote it on this slide. Finally, finished the orbit checklist. The next class will be about common scenarios in the exam. I shall give you like 3 cases, and then we will have a quiz and the closing slides. So the next class will be hopefully the last class about proptosis evaluation. Regarding the assignments, because you will need this assignment in the next class, and I will choose one of you to play the role of this experience. It's all about thyroid eye disease. Can you please read the experience? Yeah, go ahead.
Lady with bilateral legs of thalamus. I again followed same sequence of observation and explained what would I like to check on palpation and auscultation, as he asked only to tell but not palpate. Then I asked, can I measure the proptosis? Examiner says, yes, go ahead. I used Hertel's and told correct measurements. Then discussion went on to thyroid eye disease, sight-threatening conditions, management, Ugogo criteria, Rundle's curve. I could answer confidently, and examiner was happy, said good.
So we will go through this experience in the next class, because this is the most commonly encountered case scenario in the exam. As always, I ask you kindly to post one important sentence you learned from today's class. and avoid repetition. So if the previous message mentioned this sentence, try to think about another one. Okay. And what is the advantage of this kind of activity after the class? First, when you write like a correct sentence, this shows that I'm successful in translating the idea. You understood me in the class, understood my way of teaching in the class. Second benefit, that it's a kind of rehearsal, or try to memorize information after finishing the class. Third one, it might help the others who didn't attend the class to have an idea about what are the important points or pieces of information that were mentioned in the class. So please do it. I will end this class by this slide, and remember the intimacy between orbits, eyelids, motility, and pupil. And I posted this. I asked you to what are the 4 P's in a pod? I think there is a story with this title, 4 P's in a pod, and I got a nice reply. She said orbit, lids, pupil, motility. But I have just one comment. Try to say orbits, pupils. So because we have 2 orbits, 2 pupils. By this, I end my presentation. I hope you found it useful, and I see you very soon. Have a nice day. Any questions? Any pin touch, white, yellow, it doesn't matter. It's a kind of my personal preference. I like the yellow one. Okay, thank you all for your attention and your patience. Bye-bye.